Very good evening, friends and colleagues. It is an immense pleasure and privilege for me to introduce and welcome Professor T.Y. Wong. Perhaps it needs no introduction, but I would try to say something for those of you who are new to Hong Kong U, who are junior in your residency training. Professor Wong is truly a legend in ophthalmology and medicine. In his mid-50s, man has no secrets, it's available online. He has held numerous prestigious leadership positions across the world. Currently, he is the chair professor, founding head, and the vice chancellor of Tsinghua Medicine. He is also the vice provost of Tsinghua University. Before joining Tsinghua in 2022, he had been the chairperson of the Department of Ophthalmology in NUS, National University of Singapore, and also the Department of Ophthalmology in Melbourne University. He was also the Vice Dean of Duke NUS and Executive Director of SIRI, Singapore Eye Research Institute, and the Singapore National Eye Center. So this really kind of summarizes the key leading positions. There are still a lot that I couldn't cover in 5 minutes, but I would like to get you an idea how important this person is. Over the years, 30 years of career, roughly, he has published more than 1,500 papers. So that means 50 papers per year. This is a record that, I don't think I haven't seen anyone that has broken the record yet. So today we are very honored to have him to speak to us about transforming healthcare with AI and digital technology, past, present, and future. Thank you so much, Professor Wong.
Thanks very much, Professor Leong, and a lot of my friends and colleagues, some younger people I don't recognize. I think you're probably residents or maybe even consultants, but too young for me to know. So thank you very much for allowing me to come here and to really enjoy the facilities of Hong Kong U. I think I know Chris for now maybe 15 plus, maybe 20 years or so, when he was again a young assistant professor. Now he's the head of ophthalmology in Hong Kong U, and I think it's a great development. I think ophthalmology in Hong Kong has always been at the forefront, and I do hope that this department under his leadership will continue to grow, attract young people from both medical, non-medical, scientists, doctors, to grow the kind of ecosystem that's needed to really make an impact, right? Not just the Hong Kong island, but now the greater, wider influence throughout China, of which Hong Kong it's kind of part of the country and part of the ecosystem. But I think that a lot of the international thoughts must come from Hong Kong. I did tell Chris that when I comes from Beijing down to Hong Kong, I do feel I would say the international atmosphere here, and that should be maintained, right? With a very welcoming outlook for people, not even from Chinese people, but elsewhere essentially. And I think that needs that kind of innovation is needed, and I think Hong Kong will continue to play that very important role. So let me get started with this lecture, and I'm going to cover several things in this half an hour or so, maybe a little bit longer, because I have lots of thoughts to share, right? First, I'm going to talk about what are the healthcare challenges, right? You want to transform something, you need to know the problems, right? And the healthcare challenges, of course, I will focus kind of China as an example. I've been in Tsinghua for now 3 years. Challenges in China are really not much different, I would say, from Hong Kong, if I may take a look at it. Hong Kong island itself, right? But, China as a bigger problem. And really globally, right? I would say it's about the same. And I think a lot of common problems need common solutions, right? Then I'll talk a little bit about what I understand from AI in medicine, as well as the broader digital medicine ecosystem. You can't cover everything. I just want us to summarize that, and what do we know now is, of course, a very hot area here. And I would also say something about why it is not easy to just put one technology into a very complex ecosystem and say that you're going to transform everything. And I'm sure a lot of physicians, senior people, junior people always think a little bit about this. There was a recent paper, I think, I'm not sure it's in one of the major journals, I'm not sure it's New York Times or Economist, about why many companies, or it's Bloomberg, one of these, or Financial Times. Okay, sorry, I read a lot of kind of news media and I get lost with what comes up. But that said, has AI technology been overpriced, right? You know, the market valuation of all these companies. Has it made money for many products? And you know, the answer is that it's still, I won't say it's a bubble, but a lot of investment. Has it really solved problems? You know, it's supposed to make our lives better. Has it? It has supposed to reduce costs. Has that done so? Besides the people that's producing chips, which they're making money selling the chips, right? NVIDIA and so forth. What other companies have benefited from AI that has made them more profitable and more productive? I mean, it's a debate, really. And that article basically looks at the productivity is kind of like flat, essentially. So it's not that easy. So many industries not easy. Is it easy in medicine? I think all of us are looking at it with fear, with trepidation, and a little bit of hope and promise. So it's very sexy for research grants and papers, but is it really changing our practice? I think all of us are looking at that. I'm going to talk a little bit about our work in Singapore on this diabetic retinopathy screening program. I know that Chris, Hong Kong, all wants to do some of this, right? It's not just HKU, CUHK, Hong Kong authorities, hospital authorities. Everybody wants to do this. And how did we kind of do it? And we are, I would say, almost there. Not nearly finished, but almost there. And why is it almost always there? Almost there, but not completed. I think I will also share some of those experiences there, you know, because this is, it took a long time. Now I look at it, you know, I started it in probably 2008, right? This is now 16 years. I didn't believe it when I asked the NHS about UK screening program, Peter Scanlon. Now he's kind of half retired, 80. And I said, oh, you know, successful, right? National screening program, UK. How long did it take? You always say 15, 20 years. I said, no, I don't have that kind of patience. When I talked to him, I said, no, we'll get it done in Singapore. Now it's 15 years. And you think that it's easy to do. And I said, wow, it's really 15 years, essentially. But of course, I'm putting in place AI, so that's complicates a little bit more. But basically, it's not easy. Any major transformation, right? It's going to take a long time. You know, whether you want to do primary care, you want to transform your practice. You know, it took a long time for people to accept ECCE to phaco. I'll tell you, right? I mean, some countries, you know, the training was ECCE until it became irreversible, right? You know, so I think that's quite important to look at. Then I'm going to talk a bit about really the observations and lessons. In other words, can you take it to your own kind of situation and what I think is necessary for us to kind of implement that. And then I will go, of course, the past and the present, now into the future, what I think is future. What do we need? And, you know, there's this thinking from me, at least, a kind of a rough 3 phases that will happen. And we are kind of in the first phase, essentially, and I'll share some of those. So first, let's look at what the problems are, right? I always say, in fact, if you hear the innovators around the world, right? If you don't know the problems, you don't know the solutions, right? Because solutions cannot be looking for problems. And that's also one of the big things that we have. I mean, the late Steve Jobs, you know, his videos are always around. Once in a while, it's quite inspirational, right? And he said that, you know, when he went to Apple in the beginning, they were trying to create, you know, there were a whole bunch of engineers, top engineers in Apple, right? And he was saying that he really tried to do something different by looking at the customer and consumer first. What do they want, right? You know, and there's a whole bunch of, I'm sure you know those kind of stories. Very ugly looking dysfunctional phones trying to break through. Some of them are really like, all those digotides for all you know, is huge, like a brick essentially, right? And then they add on digital and so forth. And only when it came up this beautiful iPhone that it changed our smartphone revolution. So Steve Jobs was very clear, right? You need to know the customer. So in other words, for us, we need to know our problems. You need to know what the patient is feeling, what the healthcare problems are. So let me quickly, because this talk is not about healthcare itself, summarize some of these things. And the problems are, number one, right? First, disease changes, right? So this is China, but it's no different from anywhere else in the world. Disease changes. Disease changes are significant. And when diseases changes hit, we don't really understand how to react to it, because a lot of our systems and China's is the same, right? They're building brand new hospitals all the time. I've gone to really different parts of China. Beautiful, spanking, they told me it's Japanese design hospitals. I have looked at it, yes, it's like kind of like flow and everything, big rooms for people, beautiful bathrooms and everything. They have the hardware. But why did I go there? They said, oh, we don't have doctors and nurses. That's a problem. So everyone's focused on building hardware. You can do it, but you don't have the software and the people to do it. So that is not that easy to handle, right? And therefore, you have what I call healthcare policies lack changing healthcare challenges and needs, right? This is a situation in hospital during COVID in the December 2022. I don't know whether you know what happened in December 2022 in Beijing, right? It's an opening up of China, right? Opening up of Beijing, right? So everybody that needed something, go to the hospital, right? You can't get a Panadol at home. There's no other family practice to go to. Mild, sick, you better go to the hospital. That's the only way. So in other words, the policies lag behind things, and therefore you have this whole thing that, COVID kind of showed it, but any other disease, any other outbreak will kind of challenge those kind of healthcare system. This is a hospital I practice in, which is a very famous hospital in ophthalmology. This is the Tongren Hospital. For those of you who do not know, 300 ophthalmologists, right? 1.5 million outpatients per year, right? This is an impossible size. Singapore is about 350,000, right? So this is about 5 times the size of SNEC, where I work, 300 plus ophthalmologists. And of course, this is like this, essentially, right? This is waiting to go into one of the doctor's room. And to do this, I asked them, and I think when I started practice there, I was a little bit, I won't say I had a lot of cultural adaptations needed, obviously, right? For me, retinal specialists, you see a lot of diabetic patients. What do you need to do? You need to see them. It's a follow-up, right? It's not a single once-off, right? It's not a trauma. It's not a cataract. So you need to see them, right? So you need to see them. If they are severe, you see them quite frequently. If they're mild, you might see them once a year, right? That's how you manage diabetic retinopathy. And I said, can I see you next year? And there's no possibility. And I asked the nurse, says not possible, right? It's good luck. Come next year if you can, right? Because follow-up appointments in many hospitals, I do not know the situation. I think it's not, I know it's difficult in Hong Kong, but at least there's a follow-up system. It's just that when you get in, you have the follow-up appointment. You can't get in, it's the other problem that you're facing, essentially. But there, you get in, it's very lucky, right? It's very lucky. I don't know whether anyone has worked in the hospitals in China, right? But my appointment slots are online on the phone. It comes up usually the beginning of the month for 1 month period, and about 8 seconds, the slots are gone. It's basically like booking one of your Michelin star restaurant in Hong Kong. It's like that, about 8 seconds. So you either have robots doing it, or you have to have some other ways of getting the appointments through the back door or whatever it is, which happens essentially, right? Otherwise, how do you get in? And the reason why they have no follow-up appointments is because next year's slots cannot be open. Because if they open up 1 year slots, then they basically will not see anybody. Then maybe it'll be like any other country. I don't know about Hong Kong, but likely it'll be very long before you can get an appointment, essentially. So in other words, if you keep all your slots for follow-up, you have no new patients. I will only have follow-up patients. And therefore, there's a lot of hospitals do not have follow-up appointments for that thing. So in other words, this patient that is a diabetic So I treat all my patients as a single visit. In other words, I give them an advice. I don't see them again. I hope that they get something. I tell them, by hook or by crook, once a year, once every 2 years, you better get a check, right? You have diabetes, you better get a check, essentially, right? Because that's the only way. So I give them a lifelong medical advice. I got to tell them, one day you may need laser, one day you may need injections, right? These are the things. You have to treat it that way. And of course, I don't have enough time to talk to the patient, so that becomes another part of the problem. So that's what happens in many countries. Then I think the other thing in China, which happens globally, right? It's not a problem in Hong Kong. As I said, I talked to Chris, telemedicine, do you need it? When I started this telemedicine in Singapore, people are like saying, why do you need it, right? It's every half an hour, you cover the whole Singapore. Why do you need it, essentially? But in China, you need it, right? It's 6 hours, some of them. They come to our clinic, 6 hours. Because basically, everyone's looking for the same thing, right? They want quality care, at least a chance to do it, and they don't have that access. So you have, luggage is quite common, right, in Chinese hospital. They have to see it, and then they go off, essentially. So it's a single appointment. Then that goes back, you have no follow-up appointments. Then I can't keep thinking, why do they always need to go to Beijing? Because, it then covers many other aspects. Inadequate services, you have hospitals, you don't have doctors. Many things goes on in big countries. It's a middle class economy right now. It's developing, but it's really middle class. It's not the most advanced, like Hong Kong, right, in one sense, but it is also not like Africa. So what do you do with Africa and other places? Basically, it's your good luck, essentially, right? And of course, some do not have chronic disease at this stage. Then we realized that there are many things that's going on that is nothing to do with medicine, right? It's the entire ecosystem, right? It's your physical activity, it's your diet, it's your air, and so forth, essentially, right? So really, there are many challenges that, people kind of like keep thinking, how do we deal with it, right? Yeah. Then I would say, after all this, you go on to supply. So these are what I would say, disease-driven demand-side equations. Supply side means, how do I tackle it, right? So supply, number one, you pump in more money, and already it's 7%. I don't know how, it's already high by China, but low by international standards. Hong Kong could be a little bit higher, I think. US is 18%, which is something that people all want to avoid, right? So you need to balance in between. UK is probably 10, 12%, right? Singapore is about 6, 8% now, right? But China, much easier to manage, smaller country, you have a lot of this thing. And then you have that thing that they can't spend. Then you have the thing is that you have the supply part, you don't have enough doctors, you don't have enough nurses, and then you have all sorts of things that they say, the doctors are, training is too long, it's not of good quality, some universities are better, some are not. And these are not unique, right? Everyone's kind of like trying to struggle. How do we going to deal with it, essentially, right? Do we have it making tuition free? Many are New York, now Johns Hopkins free tuition to encourage people to do medicine, because some people don't want to do medicine. Actually, being a doctor in Hong Kong, it's very interesting, right? I can tell you that even though we have places in Tsinghua Medical School, it's not filled. Can you imagine Tsinghua not filled? Can you imagine HKU, you have 300 places and it's only 200 applied, you have 100 more places. Is that possible? It's not possible, right? Yeah. And because being a physician in China, it's challenging, it's difficult, it's long hours, and you're not professionally rewarded according to your skills, right? So people go into computer science and they go technology and finance sector and everything, right? Yeah. So it's not that easy. So people make it free. They try to, the situation in Hong Kong, I kind of like just added this in. I'm on the HKUST kind of advisory committee to look at their third medical school, and I keep telling them it's very difficult. Please, don't do it. Yeah. If you want to do it, it's not that easy to do it. And Tsinghua is trying to do it. Basically, Tsinghua is like Hong Kong HKUST, right? They think that it's that easy. You find one dean, and maybe you can get a medical school. Where's your hospital? Where are your doctors? How many faculty do you need? It's a huge commitment, essentially, right? Yeah. And then some schools are even better. 3-year programs in US. I don't know whether some of you know. New York, Penn State, a few of these are now shrinking their medical school because they need to produce doctors that are practical and professional, and do you need so much of those kind of knowledge in the era of AI we are thinking about? What does China do? It started with 5-year program, not so good. It goes to 6 years program, 6 years, not so good, 7-year program. Now the best university, 8-year program, right? Because to mitigate quality, they increase the length, right? So you can add more. So now it's impossible. I told Tsinghua, I said, actually, the best medical school, I want to shrink it from 8 to 5 years. No, you can't. Jiaoda is 8-year program, Beida is 8-year program, Zhongshan is 8-year program. You're stuck with an 8-year program, right? As a surrogate for quality. So a lot of things. So I haven't even gone to digital, and we know there are things that we can't handle, essentially, right? You know, and this is one with the clinics in Tongren as well. This is normal, common, essentially, right? So what can the doctors do? They are not able to say, you have diabetic retinopathy. Do you need to, okay, next patient. I'm sorry, you know, I have no time for you. You better go and read it up on yourself, essentially. But I would say one thing, right? This is a picture for SNEC that I took before I left, and I look at it and I said, it's not much difference. It's the same. I'm sure it's the same in many of our hospitals, essentially. There's not much different, essentially, right? You know, so I think there are no simple solutions for this. Now, there are many solutions, I would say there are many thoughts about how you address this thing. And this is not for me to lecture here, it's for the Ministry of Health and many governments, right? So some of the things that they do, for example, strengthening primary care, right? For example, going into preventative medicine, right? I mean, in China, they also have this thing. They call it Healthy China 2030, 健康中国 2030, right? So it's a nice slogan, right? But you need to do a lot of stuff there. You need to build primary care, family medicine. You know, there's no family medicine residency, by the way, in China. There's no such thing, right? So how do you have primary care and preventative care when you have no family medicine, essentially, right? You know, so many things, but many possible solutions. But one is to use technology, right? And I think that if we don't use technology, then you are trying to not make use of it, and which is why we go into what we think can do technology for this. And I think that I hope and believe that we will use technology to solve some of the things. I'll just give you a few examples. Do you need 100 doctors? Do you need 100 ophthalmologists, which is roughly the number in HKU? Do you need, or you need 50? Or do you need 20? Could technology help? That solves a lot of problems if it could. Am I correct? It could. Now the ophthalmologists are all concerned, the young trainees think, what am I going to do? It's true, right? Do you know that in Wuhan, if I'm not mistaken, right? You know what has happened in Wuhan recently? I know that Chinese information are not equally read by everybody in the country, essentially, including this part of so-called China, essentially, right? Driverless taxis, driverless Grabs, that's happening. So what do you do with the entire DD industry? It's a huge industry. It's a huge economic thing. So it's started, right? So it will likely start, and it will likely come. They really have one district, you know, they have that, right? So do you need so many drivers? If you don't need so many drivers, what do you do with them? You need to create economy. But anyway, technology will likely come, and we need to do this. So digital health and digital medicine, there are many definitions which I will glance through some of it because we don't need to go through all the difficult concepts. I want to just bring us up to speed a little bit because I think it's quite important to understand this thing. I read this AI and digital almost every day because there's new things happening, right? This is the fastest changing field that I've been involved in my 30 years plus. Fastest changing, right? You could miss 1 or 2 days and you say, oh, I missed the whole thing. It doesn't happen in ophthalmology, right? Phacoemulsification, you don't read it for 6 months. What's the difference? Anything? Any different? Glaucoma, I'm sorry, Chris. What I learned in medical school maybe is still the same, trying to do neuroprotection, am I correct? What else I get is still traps, am I correct? I don't need to keep up with AI. 1-2 months later, you're presenting a talk, people ask you something and you don't know, how can you be an AI expert? It's not possible, so it's not that easy. I would say it's a huge thing. But I do want to mention thing, right? It is about application, right? It is very downstream. For all of us in this medical line, we keep using technology. I mean, and there's a whole bunch of engineers and scientists looking at upstream stuff, which I won't talk about. But just the downstream stuff, I cannot consume it. Because there are many things, you know, it is like a tsunami pouring their upstream stuff into the downstream thing for us. Are we supposed to use this or that? You know, those kind of things. So it's quite important, right? But I would summarize digital health as the following. AI, of course, is one, but this whole idea that there is a component of telehealth. In other words, I don't need to be there. And I will use this as a broader term. In other words, I don't need, you have an AI, but I can do this by distance, right? In other words, you can see a patient in China or in Africa, right? Using AI, or maybe you don't need someone from there, or maybe it's a program in America. So this whole telehealth is quite an important part of it because it reaches globally. So that's another part of digital. And then I would say this whole idea of mobile health, things that are part of it, Internet of Things, they are all connected. There's almost nothing that's not connected. I think your kettle is probably connected to the internet, right? Not yet, but soon, right? You look at the Xiaomi stuff. I mean, at home, it's all Xiaomi. It's supposed to have an app, and they keep adding stuff there. The refrigerator, of course, the aircon, you know, and you keep adding, you know, I mean, that's what the ecosystem in Xiaomi is doing, essentially. You just keep adding, essentially. So it's all Internet of Things, essentially, right? And then you add on the big data, 5G network, blockchain, right? That ecosystem. That's digital health, essentially, right? So I think we need this thing. And of course, there's a lot of thinking behind it. But the breakthrough in AI came, which is supposed to be the fourth revolution, industrial revolution, was this. And this one, I was lucky to, you know, just this recent graduation ceremony, Haibon knows about this. You know, he's that gold champion, essentially. So they have bright computer scientists. I just wish he did medicine, then, you know, I have someone that's smart in doing medicine. But he's, he didn't study computer science. I don't think he need to do computer science. He studied business, essentially, right, and finance, essentially, right. But this is the graduate, but he was the first to kind of like tackle gold. He's a world gold champion, essentially. But anyway, it's a fourth industrial revolution, and of course, in ophthalmology, you know about this paper, right? This is a landmark, cutting-edge deep learning paper by Google, that group, when it came out, and you know the results are spectacular. And then they announced it at California in their Apple conference. We're going to, you know, go into AI and so forth. But if you really want to look at AI, then I think this 2023 has been significant because many people have now gotten into the AI. And I did say that in the past, we don't know what's happening, but many of the thinkers are worried about the risks. And I think that we are now starting to think maybe the risk part is something that we have not looked at. The promise part, everyone is very keen, but the risk, maybe they are seeing something very dangerous that we have not seen the product yet, right? You know, the open AI people and so forth. I'm kind of like thinking we need a little bit of thinking there. I don't know we have enough people besides all these tech companies. What I'm also worried about is that a lot of this are now, the fundamentals are driven by companies, right? No, even Tsinghua University, we are not competitive. They are all companies because you need huge engineers. We cannot pay our people enough to, you know, all these young people, graduation, they go, right? Huawei, Baidu, they're out, right? You know, you cannot keep them. I do not know Hong Kong U has a big or solid computer science department, but it's not easy to find them. So you do not know what they're thinking, essentially. But you know, but things that are happening are like this, right? So in other words, in your ophthalmology training, after a while, you don't need to see patients because all these cases will be up to you. AMD, I learn, how does it look, how do you treat? It's all by AI. It's not even real patient, essentially, right? It's going to come that way because this is the reality of generative AI. So when you look at AI, that part there, then we know, you know, this whole idea that, you know, there is that early phase, machine learning phase, and this deep learning phase, which we are all maybe heard about, right? The deep learning phase has been quite significant, and that came up with several papers, right? The Skin paper, the Google paper, our paper came up a year after that, and it was quite significant from that past. Then I would say in the 2020s, as well as in the later part, there's three major foundational things, right? The first is this, what we call the transformer model. The transformer model, for some of you who don't understand it, is the foundation, and this paper is one of the most cited AI paper. Probably you won't know it, right? But it's very famous essentially in the computer science world because it changed this neural network deep learning thing, which was supposedly looking at patterns like in the brain by looking at the next sequence, essentially like a token, the word of it. In other words, they are only interested in the next sequence of the word, which therefore led to ChatGPT, right? Which is now the foundation of it, and there are many things that happened along the way. And then another thing that came by was in ophthalmology is called the foundational model RedFound. RedFound is where it is the basis for future programs, right? So let me just maybe introduce a little bit about this, okay? I won't go into large language models. We know they are useful, but the foundational model basically squeezes what we call single disease-specific, single modality things all into one, and therefore having the possibility of multiple outputs. And the analogy, as some would say, would be a base stock of soup, right? You want to make it into a wonton mee, or you want to make it into a chicken noodles. That base stock is what the foundational models are. You can use it, tailor it, add a little spice, it suits that kind of taste, right? So the foundational model is this. And the RedFound was, of course, very significant because what they did was that they used two imaging modalities, and then they train it using self-supervised learning, so not even labeling, so that was powerful, and then it was able to do multiple tasks downstream, right? Now, this doesn't mean that it solves everything. It's just a base soup. It's not by itself tasty. In other words, it's not by itself useful. If it goes to Vietnam, they'll say it's not as good as my pho, right? If it comes to Hong Kong, it's not as good as my wonton mee, right? So the foundational model needs what we call fine-tuning, right? So if you use this foundational model, let's say RedFound in Hong Kong, you may say, hey, I have a lot more myopia patients because this is predominantly developed in the West. I need to tailor it for my local taste. But still, what I mean is I don't need to build this from scratch. I don't need to go to find the bones and the chicken stock to build that entire soup, right? That's a foundational model. So quite powerful, essentially, because it's now therefore able to be adopted and so forth. And we have initially looked at it. Again, the promise is more than what it is, but generally, it is better than building it from scratch. To build it from scratch, you need huge teams, huge data. Many of us in this room will not build without a team a normal deep learning model, right? You can't, because you need millions of images, some of them labeled essentially. But you could do from the foundational model something suitable for your clinic. Let's say a private ophthalmologist says, I predominantly see glaucoma, and I'm interested in whether or not this will allow me to predict progression of glaucoma. The theory behind it is that I have 100 cases, some with progression, some no progression. I use the foundational model as the base, and then I can fine-tune it, to retrain it, and that performance will go from what is maybe 90% to 95% suitable for your clinic, for your glaucoma patient. That's the idea. I can tell you there are many papers coming out in the next few months to show that sometimes it works, sometimes it doesn't work. So it's promising, but nevertheless was a Nature paper, right? Not anything else, because I think that's clearly the idea. Now, ophthalmology has it, pathology is having it, many other fields is going to start, radiology will have that. And what it means is that it will also democratize how people do AI. At the moment, I will tell you, whenever I give this talk, people say, you have to have a big team behind you, which we do. We have a technical team, we have a clinical team, we have people collecting data. But foundational models means that it could be done like a SPSS, a resident thinking about it, say, I can do a reasonable job with, on an AI project without needing to have massive teams to help me, right? let's say, as I said, just a few fine-tuning. So that's the theory behind it. So it's going to democratize. In other words, people in Africa could do it to suit their kind of interests and what they need. So that's quite important. So as I said, there's many thoughts about it, which I won't go into, but I would say, going back to this question, why is it so hard, right? And I'll give you that thing. Let's go back to this paper that I mentioned before, right? This paper is one of the most cited in ophthalmology, not just ophthalmology, deep learning by itself, 3,000 plus citation, right? 3,000 plus. This is maybe a year ago, maybe it's 4,000 or 5,000, right? But you know that Google has no more use for this paper because when they tried to do it in few tests, they could not get it to work. And many of these nice models, highly cited papers, there's another very highly cited paper, which is the OCT deep learning paper, done by the DeepMind group in Morpheus, in collaboration with Morpheus. You might have read about it. It's a beautiful paper, Nature Medicine. And up to now, it's not being able to be used in Morpheus because it was, it has a collaboration with TopCons, many kind of things. I'm just saying that many of these well-cited, beautiful papers, 3,000 people are citing it, right? It's not used. Because I think, again, going back to what I've said before from Steve Jobs' days, right? You want to do things like this, you do need to know and you need to bring people together. I think the scientists really don't understand it. I've worked with many scientists before. They think differently. The engineers think differently, right? They think from A to B. The clinicians think from B and say, I need solutions A. But they don't know what that solutions A are. But engineers know A and they want to go to find a B, but maybe it's not B, essentially. So I think that this is very challenging. And I think, without this kind of team and so forth, always very difficult. I try to do, I look around the world for teams, not that many groups. There's solid engineer groups. There are a lot of clinicians thinking that they would like to do AI, but it's very hard to bring it together. Because I think you need things to understand, right? You need to understand the clinic, right? What do we do, right? What do the patients go through? This is a standard retina type of clinic, right? They either get more tests or they get injections, or if they need surgery, they are rebooked. But people are inside here, and then you need to know the problems, right? And the problems are very simple. All of us know those in the clinic. I've really shown some of the problems just now, right? So these are the problems. But many engineers don't understand the problems. They have a beautiful thing, they have an app, and they say, this one can diagnose glaucoma. How come you're not using it? It doesn't fit like this in our patients, right? The 100 patients come in, none of the apps are useful for us to diagnose that disease because they don't come in with a glaucoma problem, right? So I think we need to do this because after that, then you're able to say, if you know the problem, then you're able to know what do you want to do with that thing. And then you design something for that. And you could have many things, which I won't, there are many examples, and people are now starting to say, where do I want to tackle this? And then, can I make it better for screening, which I'll talk about? Can it help with triage, which the ChatGPT now is very powerful? It probably can, with patient conversations. Can it be much better in diagnosis? Likely it will be. Is it going to help you in decision support? We have talking with some retinal specialists, on treatment and no treatment, right? The amount of fluid is now by eyeballing, essentially. Maybe it's more, maybe it's less. Why do you need it, essentially, right? If you look at ECGs, you don't need to read the ECGs, even traditionally, right? You just read the reports. Now, we don't need to see the x-rays anymore of the orbit, right? You take a pathologist report, likely one day it's going to be an AI report on the orbital MRI. So why do you need it? So I think decision support is going to be quite useful. In other words, fluid has increased 10%. You make a decision whether you want to treat. Not, I think maybe it has increased. I go back a few more visits, maybe it has not increased, right? That's what we're doing. So I think that's going to happen. Prognosis is very important. A lot of us can diagnose, but we can't prognosticate. I think even Chris maybe you see a few times, maybe you say, I can know this guy can go glaucoma progression. It's very hard. I hardly know, essentially, right? I see some, I know rapid progressors, I know those that are very mild. In between, I cannot tell. I basically have to see them all the time, according to the guidelines, right? 6 monthly, 9 monthly, yearly, according to the guidelines, because I can't predict. But AI can predict, because they have information that we don't have. So that is quite useful. Diagnosis, is competing with ophthalmologists. Prediction, it will outbeat ophthalmologists all the time. If I give you 100 photos of retina, diabetic retinopathy, I ask you which one will progress, the AI will outbeat you for sure, right? But diagnose, you probably can compete essentially, right? So I think those are important things, and I think that we will need something like this. So let's go quickly into this DR thing, right? And I'll just go through very quickly. I think most of you are ophthalmology or in the medical line, so I won't have to explain it. The problem is big. It affects one part of the body. Some of this, I think, as I said, but we know, ophthalmologists know that, the ability of it to go either way is very difficult, as I said. If I see this picture here, I do not know whether they go to each of the two routes, right? I need to see them on that 6 monthly, yearly basis, 9 monthly, or 2 yearly basis, right? If they are this, probably yearly basis, right? Up to this stage, you're still saying, should I see them, on 3 or 6 monthly basis? But I don't really know, so it's not that easy for us to do. And therefore, the management of diabetic retinopathy goes with that screening, right? That screening process that allows you to, split the people into referable and non-referable. It's a very simple kind of analogy. And it's possible because those that do not need to come, out of the 100 diabetic patients, maybe 30 really need to go to see the eye specialist. That's roughly it, right? 30 at most, essentially, right? Sometimes 20, but if you are conservative, it's about 30 out of the 100. And then when it's implemented, this is in Sweden, but in other countries, it's like possible. We have had guidelines on it, and then this is the national screening program that I'll talk about, how they've done it. Really over a long time, they told me, started with, in the early days, right, of even before digital, essentially, they have kind of gotten into this. I think, I understand that Hong Kong doesn't have a national program yet, right, essentially. Australia, when I was there, we started almost 10 years. It got into the program, but now it's still not out. It's still not out, even though there's a Medicare number, because, it's not easy. You got optometrists, you got GPs, you got ophthalmologists, then you have to deal with, all those, kind of like silos and so forth, essentially, right? So when we started this, it was already from the guidelines from Ministry of Health, right, that there should be one. 2004, I mentioned that, right? By the time I read the guidelines and started doing something, it was 2009, essentially, as I said. But we did over a long time this thing whereby we have an aim of about 50% of the population. 50% because these 50% were seen in what we call the primary care network run by the government. And the idea was very simple, right? Nurses take the photos, one batch trains another batch, so it's very simple, no need to talk to the doctors, right? So you take the doctor out of the equation, very important thing for innovation, by the way, right? For your safety, for risk, for infection control, you take the doctors out of the equation. That's the best way to innovate, essentially, right? Then they take the pictures, the photos uploaded, and that took a long time, to get a secure server that was integrated in the hospital system, by the way. Secure server in Amazon Web, they can do it. But it will never be accepted by the authorities, correct? So it has to be secured within the system. Very complicated, essentially, and then therefore you need a lot of people there. But the report came by, and the report was almost within an hour. We wanted to, when we started this, we were saying, do you need 1 hour? Frankly, you don't need 1 hour to read it. Why? It's not urgent, essentially, right? We could say 1 week we could read it. But we wanted to have, and this is where politicians are very important. At that time, it wasn't the minister, but it was like the permanent secretary. He says, give me something that I will be happy to announce. Can you do it within 1 hour? I said, yeah, well, why not, essentially? So we kind of have a criteria, right? Same point of care diagnosis. Have you heard of it? In other words, I don't need to send to the lab, wait for a week to come back. I take the pictures. Within that clinic appointment, I give you the diagnosis, point of care, within an hour. So of course, there's some brownie points for the politician, and you get something going. So I think, Chris, you're trying to innovate. You need a little bit of this because it may not make medical sense. There's no medical need to do it within an hour, right? But you got political support, much more important, essentially, I would say, in order to get that going, essentially. So that's what we did. So that became a criteria, and so the patients kind of like it. Actually, what we found was the doctors like it. You know, there's primary care doctors here, right? If the photos were sent and it's supposed to come back 1 week, it's another doctor, the patient has no idea. When it comes back, the doctor has to reread this. Even worse, am I correct? You've kind of gotten reports before. What do you want to do with that report? You know, if you need to refer, what are you going to do? You're going to call up the patient, so it's another pain in the butt, right? You have to ask the nurses to call. So we made it there and then, right? So in other words, while they took a picture, then they do all the tests, blood pressure, everything. By the time they see the doctor, the report came to the doctor's EMR. And therefore, the primary care doctor had the report, oh, your eyes are fine, it will prompt you next year. So the doctor was happy, the patient was happy, they found that, okay, it's worth the $10 Singapore dollars to do it because I get my eye tested and results out instead of it being, you know, somewhere. And if I need to refer, the doctor, same appointment, referred. And therefore, didn't have to recall the patient, so you had high compliance. I would say that in the SNEC now, in the public sector, we hardly have PDRs. Hardly. Because of this screening program, right? Yeah, this is how they are. But numbers, hardly have PDRs. So where are we seeing our PDRs, our proliferative retinopathy? They're from the other 50%, they're seeing our private GPs. So it's now changed the balance of this thing, right? Because the private GPs don't have a system. The public sector doctors, they don't even think about it. It's part of the nurses' protocol. Once a year, it comes, oh, today is your also an eye photo. You're going to take it before you see the doctor. So you need that kind of very systematic policy level change, or you depend on doctor by doctor, very difficult. So the private GPs, the cases, oh, vision blur, you better go, PDR. Right? So we don't have that much PDR. I would say I do hope to have data over time. One day, before I retire, I want to see blindness rates or DR drop in Singapore. I need that because they've asked me for that. The Ministry of Health said, tell me, is it dropping your DR blindness rate? I say, well, those kind of data are very hard to get. Long term, essentially, right? You know what I mean? Yeah. So not that easy to launch it. Singapore's supposed to be easy. I think Hong Kong can do that job as well. Then it became this thing here. And that's when we started thinking, you don't need these people here sitting there. First to be replaced. When we had AI program that came out, the thing that they all got concerned, to be honest. I got some people resign from this. Naturally, I don't need young people to sit there to read photos. Am I correct? I really don't need it, essentially, right? So that became a little bit of a concern, essentially. I mean, it's like there are young people looking for a job and so forth, you know, polytechnic kind of education, right? Yeah. So that's when we started saying, how do we do it? And that's the AI part that came in. So I've given you this this story to tell you that it's not simple to just use the AI. I already have a framework on the telemedicine system. Then when I had the AI system and we built it, you know, using a lot of data from that telemedicine framework, you know, and therefore you see the look at the AUCs, it's not that high. What was the Google's AUC? 99.1. Is it because our algorithm was worse? No, because we gave them more real-world data, so they're not as clean. So it's accurate, essentially, right? Because they are cataracts, they're poorly dilated pupils, whatever that we gave the entire thing there. Google had a nice, clean laboratory type of photos, essentially. They are all in the public domain, those Google pictures. So ours more real-world, so it's fine. Then we tested this in collaborator in Africa. I think that was quite important because we want to make sure that it is useful and kind of even in much more extreme, right? You know, this is African American eyes, poorly dilated and so forth. And so we thought that quite a good AI program. Then what do you do next? You have a program, you have a telemedicine structure. you usually say, hey, you guys have a meeting and do it. I can tell you that part there took long time to do it because it's not easy. First, you have to say, I'm going to have to talk to the Ministry of Health. They say, what do you want to do? Where are you going to put it? Are you going to put it on the cloud? You're going to put it at a point of care? Where are you going to put it, right? So then you need to think, how do you do this thing, right? So the humans were here, right? Do we replace it completely, right? Or do we have a place whereby we do a triage? The first round read by the AI, the confirmatory case by humans. And therefore, those became our secondary, what we call senior readers, essentially. But we let go of a lot of junior readers during this process. So I would say it is correct. You will let go of a lot of junior readers. So, I'm not saying there's no jobs for ophthalmologists or pathologists or whatever, radiologists, but there will be job movements, essentially, right? So that's what happened. Then we were asked to do a cost-effective analysis, which is MOH, they want to delay a program, that's what they will do, right? They make it correctly so. Is it going to save money? What does it mean? And so forth. So we did that thing, and then there's some cost savings here, and that became our tool. So we are now in the process of doing this triage. Now I would say, when we started doing this, they asked for lots of stuff. We now want a prospective head-to-head comparison. So we are still gathering the data whereby we have what we call a autonomous vehicle, but you're still driving. Do you see what I'm saying? So in other words, all the people that are, their photos are being read by the AI system are simultaneously read by the readers. And then you need to compare, and you need to compare it with the retinal specialist to kind of compare, are they equivalent? So we are now in the final stages of doing this study. It's not published data, but basically that's what is needed, essentially, right? Then you need someone to manage things. We have things that broke down, the AI program didn't work, right? And then so the technical day-to-day, who are they going to call? The nurses, who are they going to call? Couldn't be uploaded. All things you think that is easy, but I can tell you it's like anything, even setting up a computer, a presentation, all sorts of stuff. Then they need to raise money, right? Because this thing here, the computer scientists have long gone to new projects, by the way. They're not interested in fine-tuning your little stuff for you. That's not a job for professors. That's one of the problems, right? So you need people that are in companies, essentially. So I would say the Hong Kong ecosystem, I kind of like spoken to some of my colleagues here, you have the science, you have the engineers, you're going to have the papers, but the next stage, you would need the startup companies and you need industry, which is what Hong Kong is doing. Because without this, you never get it translated. It'd be a nice little paper like mine in JAMA, just like the Google paper. 2,000-3,000 citations, and people say, yeah, Singapore also has an AI program, never be used. Because it's not easy to do it. This is not a job for professors or students. They get no publications by it. All this since that JAMA papers, that early paper, you don't hear about it, essentially, right? Right. So this is where digital technology is like this, right? Tele-ophthalmology, AI system, camera, simple architecture. We didn't need it to be too, depend on 5G or something like that. You'll be in trouble, essentially, right? But basically, only addressing one part of it. Of course, it's a big problem, but it's only one part of it, right? It doesn't help with management of diabetes and so forth. Now, the good thing is that we didn't have a paper on that, but we, as Haibor knows, this is one of our healthcare science, the editor-in-chief, because it was a nice study of what to do, step-by-step, real-life experience. So now it's also one of the Singapore Management University business case study for AI implementation. The first study, they say, how do you bring it into the market, essentially, right? So the case study would have all sorts of stuff, essentially. Look at that. In 2003, we were asked to talk about, if you've done business case study, it's a little bit like this. There's a story there. Some of them are not realistic, but that's what it is. Then we're now starting to look at other things, right? So this is our team in China looking at this, predicting of progression. As I said, we can't do it. By human eyes, you can't do it. So can you predict, by time, high risk or low risk, right? Very difficult, essentially, right? So I would say that the AI could do it. We can't. Of course, we are looking at other diseases. Some of you would know this is a big field. It's a very hot field. I think there's a lot of promise, but a lot of maybe over-promise, right? This field is like, look at the eye, can predict everything, right? That kind of thing. It's nice, exciting. Some people are investing in it. I think has some potential, but each one needs a lot of work, right? Each one needs a lot of work, so I won't go into this. Then we're now going into large language models. So this one here, where we combine a large language model with the deep learning. So it's what I'll call a vision language model, which is now quite common. It's not just language. Language is ChatGPT, right? So what we do, I won't go into training, but basically we tested this with this. We said that after the deep learning program with the image, which is accurate, we did an experiment whereby we compared a primary care physician who will look at the image and give recommendation, the AI who will look at the image plus a recommendation with a large language model specific to the patient based on the characteristics, plus the third one whereby it's a co-pilot model, the primary care physician with the large language, with the output from the large language model telling them what they should do. And then we said, is the recommendation good or not? We asked 3 endocrinologists look at what they are recommending essentially to the patient, both the quality and the empathy. In other words, was the output better, right? Was better with the co-pilot model. In other words, combined together. So in other words, it will help the primary care physician be more accurate, plus more empathetic to the patient in terms of what they're trying to recommend, essentially, right? So I think that's quite significant, essentially. Now, so I'm going to go into the last 2 sections very quickly. We really talked, why is it so hard to bring it together, right? This thing. And I already mentioned you need an ecosystem, but I would say you need something that's intangible, things that are not easy to do, okay? So the first P is you need an ecosystem, right? You need many, many people inside here. And I'm glad that, I just talked to Chris, you need physician scientists. You also need engineers. I don't know the Hong Kong system as much, but in China and in many other countries, they're going to graduate program. In fact, HKU is trying to go to a graduate program. The best graduate program, in other words, in US, are coming from engineers that go to clinical medicine. So in other words, their first degree is engineer. Then they go to clinical medicine. Here, all of you are trained in clinical medicine, biology, everything along the way. Am I correct? That's Hong Kong U, CUHK. So HKUST is going to go for a graduate program. So I think they will have something around there. So Tsinghua has a graduate program. You come in, and the first few batches, half of them are engineering students. I think that you need that if you're going to bring these kind of things inside. So that's important. Then you need to know, what do people want to study? As I said, when you look at the expectations, physicians are all experts in this. How many of us are experts in this? I hope the young people think that they need to be. If they're not need to be, they really expect that they need to be. Therefore, we talk to Haibo, how do you develop a curriculum that helps them? I think everyone's trying to do it. A lot of it's didactic, some are online, but I think it needs a little bit more. I would say maybe us doctors need to know some application, how to use it. Then a computer scientist can develop it, and then you need this physician, scientist, engineers type. I do hope that some of you, if you train, if you're going to do a PhD, go into this area. There are some that's still very biology-based, probably we need it, but you need those that is going to go to digital and engineering-based, or you can't translate it. Then the second P is this whole social psycho aspect. You need to address the concerns. Many people are still concerned, including doctors, and then you need to look at, as I mentioned before, right, this flow. Look at this. How do you do a flow? Where you want to impact on it? You need to know the flow. If you don't need the flow, you have an app, you can't impact it. And I think a lot of the infrastructure is poor. The people, AI-related skills in the past is very low. Now it's going to go up. But in Tsinghua, I've tried to say, I want a data manager. I want a computer scientist. They say, oh, you want someone to fix the internet? I said, no, I want a data manager, computer scientist. They think it's an IT person fix the internet. So I cannot get anyone to do my data manager, because a lot of universities and hospitals have classified these IT people as those trying to fix this thing. But you need to pay top dollar for a data scientist. So in other words, this kind of positions, if you read The Economist 2 weeks ago, they have a very good section on AI on medicine, so you should read it. 5, 6 nice article. It's called Chief Data or Health Informatics Officer, right? They need to come from industry. They need to see the entire system. They probably are paid higher than the doctors. Where are you going to find this? Otherwise, you cannot find this, essentially, right? So a lot of American system, I would say, they are able to do it. But I do not know about HKU, Hospital Authority. I do not know whether I can tell you our own hospital. Frankly, we can't attract them. You know what I mean? So you can't do it. So you need those things. Then you need policy support, right? So this COVID, look at televisits during COVID, 2020. After COVID is over in US, immediately nobody bothered about telemedicine. So it's gone back to normal. So it's not that easy. So you need a lot of thinking about policy, which I won't mention. And then you need this kind of like patience. Genomic medicine is kind of there, less hype, more solid, slow by slow progress, right? Driverless cars will get there because it was hype and then it was disappointing, right? There was some accidents and so forth, but now it's slowly coming up to a plateau, right? I think AI deep learning is now, people are thinking maybe too many of this thing. ChatGPT is right at the hype of all this thing, solve all the world. Jensen Huang is like a billionaire, trillionaire, that type of thing, just because you're selling chips, essentially. So I think those are important. But I think we have to be very careful, right? Do not get overhyped. All of us hates our EMRs, right? Nobody likes it, essentially. Have they used AI to help us? Has it made it easier, right? We all struggle with it, particularly new versions. So let's go into the future, and we end with this, right? So the future, what do? We have many things that we are not yet able to look at, right? This whole idea that you have perfect information in a system. I've always said, students, give me a data set. That's the perfect data set. There's no such thing. We make imperfect decisions, right? You can see uncertain situations, right? When you see a patient, you don't know they're going to progress. You don't know whether they're going to you don't have that much time. You don't have, I have one of the problems with engineering students that we have going to medicine in Tsinghua is that they are very systematic. They like, if I have sequence A, then they have D. It's almost like a diagram, a flow chart for them. But we make decisions like this. You see the patient, you make a quick decision. Urgent, not urgent, glaucoma, not glaucoma, progression, not. You make it, right? It's somewhere accumulation, experience, and this whole idea that you don't have perfect intelligence. Where are you going to build those models? How are you going to do that? How are you going to get information? How do you extract those information from physicians? I don't know how we're going to do that, but we kind of like propose some of this, right? This study that we just published, taking medical into less specialized care, right? Where all those are disease, yes, no disease, severe disease, into more nuanced, no disease, half disease, subclinical disease. Maybe we'll revert back to normal. We don't have any of those kind of training. They're all disease, no disease, gold standard disease. Many of our patients have no gold standard. We don't even know whether they develop a disease over time. So it's a lot more there. And then I think we have to go into health, essentially, right? So this is the model that we are proposing. Hybor's kind of like knows this paper and so forth. There'll be a few phases. We are in the first phase, right? You will assist us, right? Traditional model won't disrupt too much of how we care. Then you have an integrated model, and I think that integrated is what we desire. You will kind of new healthcare model. 100 patients, we only see 20. There will be a new healthcare model. Now we see 100, maybe a little bit faster, maybe a bit more precise. But it'll be 20 in that clinic, right? And that will be the consults of the future, right? What we think, where it's less face-to-face, more AI, more tele-ophthalmology, right? And then hopefully it will transform and make those that have nothing. Many countries have nothing, so they are not comparing to ophthalmologists or physicians. They're comparing to AI versus nothing. They either have no care or something. I think it will transform that. And that will be the biggest transformation. So where will AI impact most? Maybe not Hong Kong, maybe not Singapore, maybe not Beijing, but in places where there's nothing. When you have nothing, AI definitely is better than nothing, essentially, right? So I think that's all I have. And this is Tsinghua. If you ever come to Beijing, I'm sure some of you have visited. It's a beautiful campus. And thanks for the chance to share this talk with you. Thank you very much.
We really are thankful for Professor Wong's insightful sharing of how we can transform healthcare with AI, digital technology. It's a Q&A section, and I would like to start asking some questions. Now, some of the challenges you share we face are basically it happens everywhere, but some of these challenges are pretty local. It's related to the local ecosystem. In China, in particular, we are also facing issues, including Hong Kong. Say, for example, sanctions of chips. There are also, since July the 9th, even ChatGPT, we haven't been able to access to ChatGPT except through the API. But since the 9th of July, the new sanction is happening where we wouldn't be able to use ChatGPT even through API. So in that perspective, do you think the challenges we are facing applying AI to transform healthcare would be even more challenging in China and Hong Kong compared with, say, in Singapore or in other parts of the world?
Well, I think, as I mentioned, I do hope and I would strongly suggest that Hong Kong maintains that very challenging position to be within China, which is what it's already happening and, will continue in that direction. But maintain that international outlook, English, international faculty, the ability to innovate, to be more asking questions, students, and so forth. Now, how would it adapt to all these new challenges of chips and US, China, geopolitics, and Hong Kong being right in the middle of it? I think I don't know the answer to that. I think the China ecosystem, Hong Kong must be also comfortable with it. Yeah, I don't think that many of you use those essentially, right? Because Hong Kong maybe still hasn't gotten used to it. There are many large language models in China. They are actually, we've tested some of it. They are very powerful. And they use, a lot of data to train. Some of them combine the standard Western data with Chinese data that the Western models do not have. So we have seen some and we said, hey, that's maybe even more powerful than the OpenAI classic ChatGPT 3.5, 4.0, because they are more powerful, because OpenAI is not able to get the Chinese data, but the Chinese data can train with the global data. So I think what I'm trying to say is this. Hong Kong should make use of that position, not losing the international perspective, but maybe think a little bit more carefully, right? You are integrating with Shenzhen in the Greater Bay Area and so forth. I would use those opportunities as far as possible. And HKU would have to either get some type of, I don't know, access or cloud or whatever that allows you to also use the Western data, because Singapore is basically taking advantage of this. It's navigating a very thin line, right? Chinese, US kind of thing. But Hong Kong must also use that and use it to its advantage, is what I would say, rather than say we don't want to use it and we are only interested in the Google, OpenAI type of large language models without using the Chinese ones. I'm sure many of you here do not know the Chinese ones. For historical and cultural reasons, you all maybe don't read some of those things that goes on there. But a lot of developments in China, and unless you are in China, you don't know those developments. And mainland China has no interest of propagating their information out. You have to either get it yourself or you don't get it. So Hong Kong people, young people, must get it yourself, or you're losing information. You're losing your advantage. That's what I'm saying. right? You're losing your advantage. Make use of the advantage is what I would do. Then you will bypass all the chips and so forth. I mean, we all know that one day there'll be the Huawei networks and the chips that will come will be equivalent, if not maybe better, essentially. So it's just a matter of time. But don't lose the ability to do both for Hong Kong. Yeah.
Right. Translating clinical research into clinical practice is challenging, which you mentioned a lot of these aspects in talk. And the transformation is challenging because it involves technology, it involves healthcare, it involves clinical workflow, and it involves politics. Now you are dealing in your position with policymakers in Singapore, in China. Can you share with us any tips engaging policymakers?
Okay, so this is very important, right? Because many, maybe I'll say, senior and young people don't understand transformation and translation and application is really dealing with, I mean, the word politics is very bad connotation, but it's basically dealing with organizations and benefits to multi-stakeholders. So what do I mean by that? This technology, there's no reason for any policymaker to want to use it. There's no reason. Unless, number one, it meets the policy's personal and ministry or the circle that he or she is in charge of. I mentioned this thing that became very important for us, less than 1 hour, right? So you cannot go to there and say, I have something that I need you to use because it's great, it's published in a paper, I think it's the best thing that happens. They need to want to use it, and they need something that benefits them. And what benefits them is not what you think will benefit them because you got a product. They got many products, they got many solutions, they got many people asking them for help. So you need to go there with something that they immediately feel that I can do it, and again, the word is not really benefit, but you have to match your incentive and your interests with theirs. That's very important, right? So you benefit them. The second thing that I think I did not say, and I usually have one of the slides on innovation, is that you need to address two more stakeholders in healthcare. Number one, patients. We have many things that the patients don't like it, and immediately that's the end of it, right? Bad experience, risk, adverse events, immediately that is a patient goes to politicians think about votes and so forth. That's the end of the innovation. So the patient is very important. Get feedback, get customer, do pilot studies, what have you. If the patients like it, you know why in Australia and America they have patient support groups. I do not know whether it's very strong here, but I know in Australia, many of the early days, right, the farmers influence patient influence politicians. I mean, it's not a good practice. It's not a correct practice, I would say, but the patient group is very powerful, right? They have an old lady says, I need injections or I'm going blind. The politicians fund it. That's what happened in Australia. If they say that I need this technology because it helps save my lives by screening, I can imagine that the politicians in Australia will fund a DR screening program. Brownie points, plus it benefits, nothing wrong to it. Patients like it, everyone's happy. But they don't have that campaign because there's no farmer behind DR screening programs, essentially, right? So that's important. So that's the second group. So patients. So the politicians align the interests. Your story to them is not a factual, technical story. It's a politician story. It's whether it can make the headlines in South China Morning Post. They can open the event, have something to say. I'm not, again, saying that it's this reality, right? I said, okay. So politicians, patients, you get these two groups, very powerful. What's the third group? Anyone knows? It's always P. Politicians, patients, one more. The physicians. In the history of technology adoption, radiology was the most likely to be overtaken many years ago by machine learning and AI, right? Why do you need to read the X-ray for TB? Why do you need it? It's impossible. Why do you have last time medical officers need to read X-rays, right? For TB screening, healthcare workers, or employment pass. You know what I mean? Radiologists. But the people that did this did not engage the physicians. In fact, the people in AI said radiologists should be afraid of their jobs. They said there's Jeff Hinton, father of AI. So you want to do this? You meet the most powerful, most successful radiologist that will say, you miss a cancer, we will fight you to the end, right? So radiology has little transformation in technology. So you do not engage the physicians, you have problem, right? So in other words, you have to co-develop it with the physician. You have to engage the physician. One of the most useful way of why this worked, this DR screening worked in Singapore was, number one, it reduced the load of physicians seeing zero, there's none or mild retinopathy, right? Helps, am I correct? So the physicians were happy. It reduced the GPs from last time having, when the nurses took the photo without this telemedicine program, they had to read the photos. I remember the GPs, it was Polaroid photos. Wow, on top of their work at the end of the clinic, one stack of photos for you to read. So it helped the physicians, it helped the ophthalmologists, both parties were happy. The telemedicine program is a nurses thing, as I remember. I mean, I don't know whether the nurses here, but nurses are the most protocol aligned for anything, right? They need to see this patient. Today is my turn to take pictures. I take 30 pictures. I have no questions. That's my job. But you don't need the physicians to do it. Immediately they accepted it, right? Then, of course, I would say what was difficult was that it will replace the human graders. And it did not replace the ophthalmologists here. When we had that, not replacing the ophthalmologist was very important for the ophthalmologists to accept this program. Because if they don't accept the program, they're also in trouble. Can't diagnose, you miss this, or you miss a PDR, what have you, you're also in trouble. So you see what I'm telling you, right? All this in translation is non-technical factors that comes from, maybe you say experience. I don't want to use the politics. I just say that it's multi-stakeholder engagement for you to be able to do it. And it's not how great the product is, not how beautiful that paper is. I would say Google came to Singapore to say, we got this Google paper, we want to put it in. And they met with all sorts of stuff because they didn't understand the thing. That's why it never worked. They say, we have the product, MOH, you should do it. I mean, there's no benefit from anybody, right? In Singapore, they say, why should we adopt this? It only benefits Google, their stocks go up. There's no interest from either the doctors or the Ministry of Health, and all sorts of stuff. And it failed because Google is like this, right? You know what I mean? So they say, it doesn't matter, I'll go to another country. That's what they did in the hubris of Google, which is normal, essentially. So translation is like this. Innovation is like this. Yeah.
So the current AI program used in Singapore, how is the business model look like? I mean, what was the cost of the AI implementation, and how is it going to be viable, sustainable, and being cost effective in the long term?
Yeah. Basically, it needed to enter the payment codes. That's very important, or it's not sustainable, right? And the payment codes are very fine line. The company that is doing this, the Iris company, basically makes a loss for it to be here, for it to be there. But they made a decision, right? That company made a decision. I mean, I have to say I'm a co-founder, so I have a little bit of very small conflict of interest there. But they make a decision to say, we will use this here, even if it costs us, because we are able to demonstrate that the government is using it in Singapore, right? Then they go to any other countries. Singapore government, very meticulous, must be correct, right? So they did. So actually, it's not making a single cent out of this thing. In fact, losing money. Because the infrastructure cost is very expensive for IT. That's number one. And Ministry of Health is very stingy with screening, right? You know this, right? You ask them to do screening, they won't fund it. And patients do not like to pay for screening, correct? Yeah. The good thing is that there was an existing fee already for years ago, right? If I introduce it new, it'd be very hard. As I said, it's 10 Singapore dollars, about 50 Hong Kong dollars, or 55 Hong Kong dollars. And the Ministry of Health pays the other 50 for the back-end AI and the manual grading. So in total, it's about 26 Singapore dollars, right? And that become a normal operating. Once you are in the operating budget, you are able to kind of relax, essentially, right? I think it needs that kind of thing, because to get it into an operating budget of the Ministry of Health expenditure is the most challenging. Yeah.
Dr. Angie Fong is our clinical associate professor. She's overlooking the RAM program here in Hong Kong. Basically, it's a Hong Kong DR screening program. Perhaps Angie can comment on what we're doing here, and perhaps you also have some questions for Professor Wong.
Hello, hi. Hi, Prof. Actually, Prof is my mentor in the APVRS Leadership Development Program. So really, really, really nice to see you in Hong Kong here. So since I came over to Hong Kong I took over the supervision of the diabetic screening program. So I still remember seeing you more than a decade ago in Hong Kong, you and Professor David Wong started the RAMP program. Yeah. So the RAMP program is the nearest thing we have to a national kind of screening program in Hong Kong. And it is modeled after the UK national program. So we have the RAMP program in the majority of government the GOPCs in Hong Kong, but it's not extended to the private market or the specialists. So if I would say it covers, I don't have the exact figure, but maybe around 50, I would say, but not. I don't have the exact figure. Don't quote me on that. So the majority of diabetic patients who is being seen in the outpatient government clinic in the HA system will be covered with the RAMP program. So it covers all the clusters in Hong Kong. And the Hong Kong U overlooks the quality assurance program. And also we're responsible for training the RAMP optometrists.
Oh, I see.
Yes, so they undergo a rigorous training program, and they have to grade several thousand images in order to go from level 1, 2, and 3, and then after that they graduate. And then they are rotated into the GOPCs to take fundus photos and to grade them. So the program would be like there's a primary grader and a secondary grader, and if there are any discrepancies, then it will be sent to us, Hong Kong ophthalmologists, to do the final arbitration grading. And within a month, we don't have the 1 hour 1 hour turnaround time. So within a month, the final grading will be out. And when the patient goes back to the GOPC for the follow-up, to see the doctor actually, because during the photo taking they will not be seeing the doctor. So the primary doctor would explain the diagnosis to them, and then also to give them recommendations based on our final grading. Yeah, so that's
yeah, I mean, I think I've heard it before with you. I do have a few suggestions, but I think you're doing it correctly. Number one, you have to have patience, right? It's not easy to do. You do need good data. You need good data managers to kind of like document those things so that you have you are able to report on things essentially. The third thing that we did in the Singapore program before we put the AI, I'm sure it's suitable for AI, which is likely, but it's another step. As I said, it's not that easy. We did so many years. Get that framework right, people are comfortable and so forth. The optometrist is a good option, the training and so forth is all fine. To look at making the processes even simpler. So if they come for just a photo, do they want to come? That's the thing, because the additional visit, right, essentially, right? So we combine it, which is why it's part of their appointment, right? So they have to come to get a medicine, they get a photo, as I said, they get it within this thing. It facilitates the entire process for the patient. So that's something that you consider. I'm not saying that it's easy. I'm just saying that, it's something to, you want the patients to have high satisfaction. When we started the DR program in Singapore, we keep giving them feedback and they become very high satisfaction. So that also persuaded the policymakers to continue it, essentially, as I said, right? Simplify it. So they don't even need to come. So it used to be, as I said, before all these things, number one, they might come, take a picture, 3-4 weeks. If they might get a call. Some people miss calls, so they get a few calls to say that you are fine, come back next year. Or if you are worse, you need a referral, you need to go back to the clinic to get a referral letter. That becomes 2 visits, essentially. So we simplify 1 visit for those that needs to go. And we also had the doctor also explain the thing, why they need to go at the same visit. Very important, right? Because otherwise you can't have a nurse say you need to go to the eye clinic. They say, why? I'm still seeing well. So we created a lot of stuff patient-centered, essentially. Made it easier, smoother, and therefore that program became quite essential part of the primary care thing. So you should take a look at that. We also got some experts in, I don't know whether you want to do it, maybe Chris, your thing about that. We got Peter Scanlon come in, look at our program, evaluate it formally, right? So that you're not kind of policing it yourself, essentially, right? So we got it as an expert from UK to come in. Then they reported back to the Ministry of Health so that there's a little bit of control again to satisfy the politician that you are helping them evaluate the program, essentially, right? So some of this helps with making sure that it's consistent, it's there, any problems, they would say, yeah, well, we've done it. We even got an expert to evaluate it. This is international standards. So there's no risk involved for everyone, essentially. That will sustain the program. Then the AI part, you need another team and so forth to do it. It's not that easy. But I would, of course, encourage you to start thinking about that. That will help a lot. But you do need to address something. You need to address the optometrists who might want it to read it, right? That was one of the problems in Australia, right? Because when they have the code for screening, the optometrists could make quite good money reading photos, right? That's the Australia system, like 35 Australian dollars. Why would they want the AI program to read it, right? $35 for the optometrist. So you have to address that. But the Singapore one is graders paid by MOH, so they could make that decision. It's not paying to the optometrist, essentially. So that was an easier decision. So along the chain and the business model, you have to look at those things. Yeah.
We have a little bit different problem. So it is within hospital authority, and they would like to develop everything in-house. And apparently, a statistical team has developed an in-house diabetic screening model, which the hospital authority management really want to push. But then I was like, no, it hasn't really been properly evaluated, and then who is going to be responsible if anything goes wrong, right? So your advice would be to bring in an
so again,
expert.
we did it a few ways, right? I mean, I only show a few steps along the way. The first, standard retrospective evaluation. Get your 10,000 or what have you, right? And so it's retrospective, good enough AUCs, and you tweak the program. We tweak it to extremely high sensitivity for vision-threatening retinopathy, 99.9. Don't miss a single case of PDR. So you will have lower sensitivity for, in other words, you over-refer, right? Yeah. It's okay, right? You over-refer, but no miss anybody, right? So the threshold is up to you. The AUCs don't tell you the threshold, right? Because it's a generic. But you need to make sure that you don't miss a case. That's number one. Second, after that, you will have to do that prospective comparative study, right? AI versus the optometrist, gold standard yourself, that kind of thing, right? Then the third we did is what I would say a little bit of cost-effective analysis to kind of like produce them. Of course, they have risks, but you have to see that how much you're going to save, right? You don't need to pay so many optometrists reading it, so how much. The fourth is that we always feel a co-pilot model is better. Don't have nothing. Don't have nobody at the end of it, essentially, right? Therefore, it's a triage model, right? In other words, we are not taking everything off, we're saying the normal cases don't need a second reader, except for a proportion that we sample to make sure that it's still quite normal. But all those that need referral have a human reader, the optometrist, essentially. So you need all this phased approach to be able to implement it rather than say, we have this program. Because you ask all the right questions, the politicians don't want to hear it. They say, yeah, all these questions are there. You cannot answer it. I cannot help you, essentially. Therefore, you get stuck. You need that sequential steps.
Question from the audience?
Hi, Professor Huang, and very nice talk, and really learned a lot. And I'm Philip Guo, Professor Long's PhD student, and I actually have two questions. One question is about the large language model. As we know that the hallucination issue is quite popular in large language model in GPT and in cloud, and by customers the model by using fine-tuning aid in using ophthalmology data, the issue can be kindly solved. But from your perspective, do you think the accuracy of current customer large language model or vision language model is accurate enough to be applied in clinic, or what's the role of the large language model or vision language model can be used in clinic? And that's the first question.
Yeah, I mean, I think hallucination is a risk, and all of us are worried about it. Just like, this is a new type of term, right? Hallucination is really for large language model, and you're worried that they ask them to not take medicine when they should take, all those kind of things. So what do you do with this? How do you use large language models in medicine now, right? So again, a very nuanced approach is there. You're going to leave it to everyone, you are going to be really in trouble, right? Yeah. I think a co-pilot will be useful. So the first co-pilot means that the large language model should not be a direct patient communication. It needs a human to use it, read it, certify it. If it is a management recommendation or something, it needs some humans to take a look at it. That's the first thing. The second is that you have to define and make it narrow. Right? Don't make it large. Make it narrow for safe situation. What are safe situations? Generally, it's normal health advice. Patients that are not sick, not with severe disease. So you do need to test it in those kind of more narrow, less risky situations. So the hallucination has no effect. I mean, hallucinations are really there for all sorts of stuff in our phones and our videos, right? They're generating all sorts of things, but who cares, right? Because there's no risk involved. So you need that kind of, so you need a defined condition whereby there's very little risk, or a decision whereby there's a hallucination that comes in will not impact on the outcome. What are those conditions? Maybe it's dry eyes, maybe it's refractive errors, those kind of things. So what if they come back 1 year later? Nothing's going to happen. Then I think it's fine. You'll be in trouble if you look at wet AMD, severe glaucoma, all this kind of thing. You don't want to start with those kind of disease. Yeah.
Thank you. And the second question is about the foundation model. As we all know that the Retifund is very powerful and it can save a lot of resources and data by fine-tuning. And besides the application of foundation model, for those researchers, if you want to go further into the foundation model region, do you have any suggestion about the potential future direction? What can we do?
I mean, I mentioned a little bit about the direction of what I think future models are, right? The foundational model currently are very disease-centric, number one. And they are not, the soup is not that nice, to be honest. And you need to add a lot of ingredients and you need to cook it a long time. So in other words, it's a bland soup. You need a much more sophisticated soup, right? So in other words, as I mentioned to you, this current soup is suitable for one taste and maybe it's suitable for a Western audience. I do not know whether we want one in Hong Kong or China or wherever it is. So likely there'll be a few foundational models that come about. That's the first thing. So it's not the end of foundational models just because there's one that out there. The second is that it is very hard to cook the soup. In other words, what do you mean by fine-tuning? Can NG, do you know how to do fine-tuning? You can't do it, essentially. Maybe you know how to do it. I also don't know how to do it. I need my team to do it. So in other words, it's not that easy. You buy that thing there, it's not putting it in, add a few more stock, and it's like instant noodles, It is still, Michelin star great kitchen. You get that stock, you still need to really do it. So that foundational model is only a concept, right? I've asked them before, how easy is it, right? It is certainly not something that people in this room can do. Maybe you can do it, essentially, right? You need a GPU, you need data, and it is not like something simple. So what do I envision that? I think the usability is the key. A foundational model that's usable will be like this, right? It has a web page. You are in your clinic in Sha Tin, right? And you say, I want to use this foundational model to help me with my glaucoma cases. What am I going to do? I don't trust the generic one. Maybe it doesn't suit my clinic. So I want to fine-tune it, right? So it will prompt you, you want to fine-tune it at 100 images of what you feel is normal, right? Another 100 images of what is abnormal. You see the output, the large language model, the details, you grade it and whatever it is. And then by the time you finish this 1 day of so-called fine-tuning, that model is suitable for your clinic. That, I would say, will be the foundational model that is the average clinician can use, essentially. We don't have that now. You take a look at Red Found, it's on the internet, you download it, you don't even know I don't know what to do with it. You can do it, but none of us here do it because it's a code, right? So that's not, to me, user-friendly foundational model, but the idea is correct. That's why it's in Nature, essentially, that paper. But many more foundational models are needed, and as I said, easy, code-free, foundational model for dummies are needed. Dummies are like doctors like us, essentially. Then you'll be ready, essentially.
Okay, thank you.
So Philip, before he joined us, he was an engineer from Audi, and now he is helping us to build the multimodal foundation models for a lot of different applications. Other questions, please?
Hi, my name is Jennifer Hong. I'm a retinal specialist in private practice now. I just had a tangential question, actually, about AI drug discovery, and just want to see what your opinions would be, with its potential applications for treatment in ophthalmology or other diseases. Is it quite an area of focus in China now? And is that something that, say, foundational models could help with? Thank you.
Okay, so this is another thing I've asked my professors in pharmaceutical science. Does it mean the end of your kind of like single biomarker target, and then get a target, and then you test it in small animals, large animals, right? That's the traditional. Then phase 1, preclinical and phase 1. I asked them, and I think that they have the same issues as us, right? The idea that you could use AI to screen for all targets of a single disease and therefore find new targets that are able to be druggable and mechanism of action is correct, I think is still quite far from what these experts are telling me. It's like healthcare, as I said, essentially it's not impacting. So we will have to wait, right? I think that the AI for drug discovery is currently like the GWAS era, if you know what I mean, right? It can come out, you can screen all targets using AI and they'll come up with peaks here and there. But what do you do with it? Are they real mechanism of action? Can you create a protein or antibody against those targets? No one knows what it is, essentially, right? So it's quite early days, is my sense, essentially, yeah. You have another question on, what's the other question besides drug?
I wanted to ask if foundational models is something that can be used in this area.
Yeah, of course. Yeah, I think they will use foundational models for it. Yeah, this foundational models is another term that we have to be very careful about overusing, right? Because if you have many foundational models, then nothing is foundational. then it becomes a very specific model. I asked this before. A foundational model means that I'm supposed to do everything, essentially. But now I know that it's not really foundational. It can't do everything. If I have a foundational model for angle closure glaucoma plus open angle glaucoma plus pseudo exfoliation, then it's not a foundational model, right? So I kind of worried about overusing that term. I mean, I'm not an expert in this, but those people already said that, it's just another model, right? It's another better model, yeah. But so yeah, that's where we are at now, essentially, yeah.
AlphaFold attracts a lot of attention for drug discovery, and I think a lot of industries are very much interested to look into how this can evolve to development of new drugs and for drug discovery and for new therapeutic application. So AlphaFold is exciting. Any other further? Okay, please.
Hi, Tien. Very glad to have you back since March, I think. So one of the areas that Hong Kong is not really moving or moving very slowly, if at all, is the legal regulations and compliance in AI, and especially AI in medicine. And even after COVID, telemedicine is also a great area. So can you enlighten us on the progress in, for example, in Singapore in these aspects?
I think both Singapore is maybe more like mainland China than Hong Kong. I might even say that. Quite interesting, essentially. But, it is very government directed. Here is quite democratic, right? As you all know, essentially, right? Yeah. Very government directed. It's a really identified technology and AI as its next new frontier, just like China has. So it's putting policymakers, advisory boards, right, pumping money into getting it faster, legal, safety, and with guidelines and policy statements very quickly. Less debate than what you would need in a more complex democratic kind of situation. I don't know whether Hong Kong fits that, but maybe it does fit a little bit like that, as I said, right? Singapore is like a small version of China. Maybe that's why I'm still surviving in China a little bit. Yeah. If I'm from Hong Kong, it'd be very tough, essentially, yeah. But that's what it is. So it has put all those things together, right? It's brought in experts, policies, ethics. It has set up institutes looking at all sorts of stuff, to try to make sure that it's the first to have legal, ethical, well-governed AI things right into downstream, which is why they were very happy about this. This was what I would say a pilot approval for it, right? This AI, which is Singapore, the first health authority approved algorithm, and they wanted to demonstrate it, essentially, right? They could do it, which is also one of the reasons why, as I said, the politicians feel that it's correct. So, it's been highlighted as an example of AI helping with cause, big problem, that kind of thing. So I think Hong Kong should and must also push this. If I'm not mistaken, Hong Kong is now also going to science and technology, right? I look at all the science hubs and the ecosystem is there. So you should push for some of these things, but it needs to be fast. Hong Kong can do things very fast. It needs private sector involvement, and therefore you are able to push it. I mean, it has a lot of other advantage. You have a lot of private sector entrepreneurs here, so you have to make use of that, essentially, yeah. I think, yeah, that's my sense, but that part needs to be done. The other problem I would say is that we don't have many good experts. It's really, just like when I said doctors, trained engineers, there aren't any, right? Am I correct, in Hong Kong? Very few, right? Are there lawyers trained in AI? I mean, we're trying to look for people to speak on this thing. This cross-disciplinary field is very little. So doctors in AI, very few, right? Engineers do AI, no problem. The lawyers and the policies have done standard things. But those that knows AI, they don't know. They don't know the engineer field. So how are they going to know this field, essentially, right? So I think that those are, the challenges. You need major things. So what Singapore has done, they hired global recruitment people that have done this kind of stuff. Policy makers that have done AI global. Strategic hires, that kind of. international advisory boards to help the government. So I think Hong Kong can do it. Hong Kong, maybe the university, don't wait for government, I would say. Universities and the private sector should do it, essentially. And if you are in the medical line, Ministry of Health, you should start thinking about that part there. Because if you don't think about it, it's going to hit you and you'll be unprepared. It's not common sense to regulate it, It's not that I've done this clinic before, I know how to do it. I think the knowledge gap is very wide. Right, I don't know this subject, to be honest. I don't know it. I'm reading as much as you are. So you are as good as me in this subject itself. And I feel that, if I don't keep up, I'm out of date. But some of you don't even know about this, right? So you are not even as reading as much as me. That's the only thing. So how are you going to regulate a policy, right?
Last question at the back.
Thank you so much, Prof. Wong, for your kind sharing. My name is Venice, and I'm an ophthalmology resident from the Hong Kong Eye Hospital. As you have mentioned, there are very few physicians who know AI. So I'm really interested in getting in touch with AI, but I find it really confusing, like what kind of materials or what courses I should start or what I should be really exploring. Would you have any tips or advice that you could share?
No, I mean, every medical school is starting some of this. If you go to Stanford website, there's an AI in medicine PhD. I don't know what they're going to train, but that's what they're doing. All these top ones will have it, right? I don't know whether Hong Kong U has it. We're trying to start some, right? I would say it's not easy because you don't have the correct teachers. You don't exactly know what you're going to teach. You don't know whether you need them to know coding and do you have data sets for them. So the whole thing is a little bit unclear, right? So what would I do if I were you, if you are young and a resident and so forth? You just have to, number one, take real dedicated time in this area, right? I think my knowledge of this field, as I said, I'm still an amateur. The foundation is very strong because I did public health and epidemiology. So my foundational data skills, right? I mean, seeing the 2 times 2 tables, all those things are very strong, right? So I will go into data science first. I don't think you need to know so much pure AI language models. Data science, comfortable with data, like how you are comfortable with clinic. So there are a lot of these. These are more mature courses. So the advanced biostatistics are frankly a little bit like AI, they're modeling essentially. So if you know how to look at equations, know how the large data, so 1,000 data is 1,000,000 data is the same essentially, right? It's just larger. Then I think that's found extremely good foundation. And there are many data science, biostatistics equivalent type of things. Start with a master's or do a formal one. All right, don't need to be in medicine, just need to know what it is. Maybe the public health ones are not bad. Then if you're interested, maybe those PhDs will be future, essentially. But I don't think there is a good PhD as far as I can see in AI at the moment, right? But that's what I would do. So the young people, I would strongly encourage you. If you're a medical student, even better. Really have to do that part there.
Simple solution, get yourself engaged in an AI project. And I think it's similar to when I was asked, how to run the statistics. You have to get engaged with the data. And for AI, I think it's good for you to get engaged with an AI project. Get in touch with Dr. Carol Zhang. I am sure you would find a lot of rewarding experience with her.
Exactly.
Thank you.
So, thank you so much, Professor Wong. I think it's really an eye-opening and insightful lecture that you share. You are definitely a forerunner in healthcare transformation.